Hi everyone. Let's learn ECG with MJ.
Aye, kid.
In order not to miss out anything, it is better to analyze the ECG in a systematic way. 1 rate, 2 rhythm, 3 axis, 4 PQRST waves, 5 segments and intervals.
Interesting.
Let's see how to calculate the rate. Rate is calculated using the formula 1500 divided by number of small boxes between 2 consecutive R waves, or 300 divided by number of large boxes between 2 consecutive R waves in the ECG strip.
How did they make it up?
Good question, Jenny. Let's derive it. Can you tell me the rate at which the ECG paper runs?
25 millimeters per second?
Correct. So, the heart rate is calculated for 60 seconds. In 60 seconds, EKG paper runs 25 millimeters per sec for 60 seconds, which is 1,500 millimeters. The number of heartbeats in the 1,500 millimeters gives us the heart rate. Each small box is 1 millimeter. If there are X small boxes between 2 consecutive R waves that represent 1 heartbeat, that is, X mm, then for 1,500 millimeters, the number of heartbeats are 1500 divided X number of small boxes. If we are going with number of large boxes, each large box is made of 5 small boxes. Hence, divide the formula by 5, that is, 1500 divided by 5, which is 300. Thus, 300 divided by X number of large boxes gives the heart rate.
Wow! That was a great explanation, Maverick.
Another easy formula is heart rate equals the number of R waves in the entire EKG strip multiplied by 6.
How is that possible?
The standard 12-lead EKG is a 10-second strip, and hence 6 times the R waves in the EKG strip is the heart rate. This technique is usually helpful when the R waves are few, as in bradycardia, or irregular R waves, as in atrial fibrillation.
Interesting.
We can talk about abnormal rhythms in a separate video, but one should know what a normal sinus rhythm is. The atrial depolarization, which is represented by the P wave, originates from SA node and moves lateral to the left atrium, which is represented by positive P wave in lead 1 and AVL, as well as it moves inferior in the right atrium towards the AV node, which is represented by positive P waves in lead 2, lead 3 and AVF. Also, since it goes away from the SA node, the P wave is negative in AVR, which represents activity from the SA node. Thus, to call an ECG as normal sinus rhythm, the P waves should be positive in lead 1, AVL, which are also called as lateral leads, and 2, 3, AVF, which are also called as inferior leads. Also, P wave should be negative in AVR.
Wow!
The overall electric vector passes in the direction of lead 2, which is also known as the normal axis lead. In this electrical axis diagram, you can see the normal axis, which extends from -30 degree to +120 degree. Also, you can see the region represented by right axis deviation, left axis deviation and extreme axis deviation. To determine the axis, identify the isoelectric limb lead first, that is, the lead where the net positive and negative vectors in the QRS wave are equal. Then, identify the lead that is perpendicular to this isoelectric lead, which gives the axis. Let's do an example. Jenny, can you identify the isoelectric lead?
AVL?
Correct. So, let's see where it stands in the vector diagram. Now the perpendicular lead is the lead 2, which lies in the region of normal axis. Hence, this ECG has normal axis.
Maverick, I am getting impatient. Is there any easy trick to figure out the axis?
Of course, Jenny, who doesn't like shortcuts? Here is a shortcut. Look at the overall QRS vector just in the leads 1 and 2. If it is positive in lead 1 as well as lead 2, it is normal axis. If it is negative in lead 1 but positive in lead 2, it is right axis deviation. If it is positive in lead 1 but negative in lead 2, it is left axis deviation. If it is negative in lead 1 as well as lead 2, it is extreme axis deviation. To remember further, if lead 1 is negative, we can make the letter R out of 1 and thus it is right axis deviation. If lead 2 is negative, we can make the letter L using the two limbs and thus it is left axis deviation. If both are negative, then it is extreme axis deviation.
Wow, Maverick. That's impressive.
Let's talk about the P wave. P wave represents atrial depolarization. As the wave of depolarization spreads from sinoatrial node to right atrium followed by left atrium, the first half of the P wave in lead 2 represents right atrial depolarization and second half represents left atrial depolarization. P wave is biphasic in V1 as the vector moves anteriorly towards V1 initially during right atrial depolarization, causing a positive wave, and then moves posteriorly during left atrial depolarization, causing a negative wave. In right atrial enlargement, there is a tall P wave in lead 2, as the initial half of depolarization is prominent. It is defined as voltage greater than 2.5 mm or larger than 2½ small boxes. Also, in right atrial enlargement, there is prominent positive or monophasic positive P wave V1. In left atrial enlargement, there is a broad or biphasic P wave in lead 2, as the latter half of depolarization is prominent. It is defined by duration of P wave greater than 120 milliseconds or 3 small boxes. Also, in left atrial enlargement, there is a prominent negative or monophasic negative P wave in V1. QRS waves represents ventricular depolarization and it is best studied in the precordial leads V1 to V6. It can be divided into two major phases. In phase 1, there is depolarization of the interventricular septum from left to right, causing a positive R wave in V1 and a negative Q wave in V6. In phase 2, there is depolarization of the right and left ventricles. Overall, the vector is leftward and posterior due to more massive left ventricle myocardium, causing a negative S wave in V1 and positive R wave in V6. The amplitude of the R wave gradually increases from V1, whereas the amplitude of the S wave gradually decreases from V1 in a progression pattern that the amplitude of R wave and S wave are equal in leads V3 and V4 in a normal ECG. V3 and V4 are hence called as transition zone. Poor R wave progression is a common ECG finding that is often inconclusively interpreted as suggestive, but not diagnostic, of anterior myocardial infarction. Right ventricular hypertrophy is defined as dominant R wave in V1 that is greater than 7 mm tall or are divided by S ratio greater than 1. Also, right ventricular hypertrophy is defined as dominant S wave in V5 or V6 that is greater than 7 mm deep or are divided by S ratio less than 1. There are multiple ECG criteria to define left ventricular hypertrophy. The most commonly used one are Sokolov-Lyon criteria, which is defined by the depth of S wave in V1 plus the height of R wave in V5 or V6 greater than 35 mm. Modified Cornell criteria is defined as the height of R wave in AVL plus the depth of S wave in V3 greater than 20 mm in women and greater than 28 mm in men. Also, notice the discordant T waves in right and left ventricular hypertrophy. Intrinsic impairment of conduction in either right or left bundle, also known as intraventricular conduction disturbances, leads to prolongation of the QRS duration. While the normal duration of the QRS is less than 100 milliseconds, QRS duration of 100 to 120 milliseconds is called as incomplete heart block, and QRS duration of greater than 120 milliseconds is called as complete heart block. Right bundle branch block causes delayed activation of the right ventricle. These are SR pattern in V1 to V3 causing an M-shaped QRS complex. Also, there are wide, slurred S-wave in the lateral leads, that is, 1, AVL, V5 to V6, causing W-shaped QRS complex. Left bundle branch causes delayed activation of the left ventricle. There is dominant S-wave in V1 causing a W-shaped QRS complex. Also, there is a broad monophasic R wave in lateral leads, that is, 1, AVL, V5 V6, causing M-shaped QRS complex. An easy mnemonic to remember is Marrow and William. M-shaped QRS in V1 and W-shaped QRS in V6 is seen in right bundle branch block as in the word marrow, whereas W-shaped QRS in V1 and M-shaped QRS in V6 is seen in left bundle branch block as in the work William. A segment in an ECG is the region between two waves, whereas interval includes one segment and one or more waves. Some of the segments and intervals to remember are PR interval, which extends from beginning of P wave to the beginning of R wave. The normal duration of the PR interval is 120 to 200 milliseconds. PR interval of greater than 200 milliseconds is seen in first degree AV block, whereas PR interval of less than 120 milliseconds is seen in pre-excitation syndromes or junctional rhythms. Jenny, do you remember the normal duration of QRS interval which we discussed earlier?
Up to 100 milliseconds.
Excellent. QT interval is very important as the prolongation can be even fatal, which can be caused by electrolyte imbalances including potassium and calcium disorders as well as by drug interactions. As the QT interval varies with heart rate, we calculate corrected QT interval. One of the commonly used formula is Bazit's formula, which is the duration of QT interval divided by root of R interval. The normal QTC is 440 plus or minus 40 in male and 460 plus or minus 40 in female. QTC greater than 500 increases the risk of torsades to points. So, Jenny, can you interpret an EKG now?
Of course, Maverick. I feel so confident now. Thank you.
Good luck.